The next section, there's a case-based discussion on optimizing a cirrhotic on the waiting list. May I invite the chairpersons, Dr. Ashok Chaudhary, who's an associate professor of hepatology at ILBS New Delhi, and Dr. Shweta Singh, who's the director of anesthesia and critical care at Max Hospital, New Delhi. And we have as a moderator for the next section, we have Dr. Kaser Raja, who is the director and lead consultant of hepatology at King's College Hospital, Dubai. Over to you, Dr. Kaser, and he will introduce the panelists. Dr. Kaser?
Yeah, sorry, I didn't switch on my mic. First of all, I'd like to congratulate Charles and everyone else for organizing this wonderful hepatology and transplantation course. I would like to invite all my panelists, which is Dr. Chandan Kumar, Dr. Parijot, Dr. Selva Kumar, and Dr. Sachin. And I would like to share my screen. One second. I hope you can see my screen.
Yes, we can.
Yeah. So essentially, we are going to have a kind of a half an hour, 45-minute discussion on care of the decompensated cirrhotic patient who is on the waiting list. We'll take a hypothetical case. It's actually a real case, slightly modified to suit the case presentation. Yeah. So basically, we're going to discuss a high MELD alcoholic cirrhotic who is apparently waiting for a transplant. We are assuming that he's listed for a DDLT, but he's also considering living donor options. Our goal as hepatologists and intensive care specialists is to prevent waitlist mortality and dropout. And in this waiting period, we have to somehow optimize clinical status of a high MELD patient with a view to reduce perioperative morbidity. And the common problems which all of you would agree in these patients are related to liver disease, which is infections, bleeding, encephalopathy, very importantly, fluid and electrolyte disturbance, renal dysfunction, and of course, other organ dysfunction, especially cardiorespiratory issues, nutrition, physical fitness, and not to forget psychological issues. Now, we're not going to discuss all of these. We're going to discuss only some of these issues. So let's start with the case. This is a 42-year-old male, alcoholic liver disease diagnosed. So we're not going to go into differential diagnosis. Presented with jaundice and ascites 3 months ago. This is his first presentation. So in the background, he's been drinking alcohol, but he never had any episodes of jaundice or alcoholic hepatitis. He's past history of obesity. He was quite obese and had a gastric bypass 6 years ago. Currently, his BMI is 28. It's quite fluid overloaded. So this BMI might actually be even lower than 28. He's a known diabetic, but well controlled without any drugs. He's abstinent since these past 3 months. He had one episode of esophageal varicose bleed and was banded about 2 months ago. His bilirubin at presentation 3 months ago was 24 milligrams per DL. And over the previous 3 months, it has reduced to 10 milligrams. So the bilirubin seems to be improving. The INR also seems to be improving a bit from 3.5 to 2.4. The creatinine is about 1.2. He's always been hyponatremic around 125, 26, and he's hypoalbuminemic. He has had worsening of ascites in the past few weeks and has one LVP done. There is no history of any infections, SBP, acute kidney injury, or encephalopathy. So if you do his scores, his child C would be 13, sodium MELD would be 32. He's very, very sick. And the discriminant function, since he's alcoholic, if you wish to do it, it's about 72. Now, this patient was referred for transplant at 3 months after the onset of illness. So, these patients are challenging. Should we transplant them? Will they improve if we keep on observing them? And if we have to transplant them, how can we transplant them? There are challenges with listing these patients for DDLT. These are more of legal issues with your authorization committee and all those things. So can we start with Dr. Chandan? Dr. Chandan, what do you think are the challenges in transplanting these patients with alcoholic disease, liver disease who present with such high MELD? And especially in this case, you would agree that this patient needs a transplant, but how are you going to assess the alcohol addiction issue in this patient?
Thank you, Dr. Kaser. So this is a case of decompensated cirrhosis, alcohol related, and definitely he does need a transplant because he has been absent for 3 months and he still continues to have liver synthetic dysfunction. Now, alcohol liver disease also has extrahepatic effects, like they'll have some pancreatitis, they may have chronic pancreatitis, they may have neurological issues like Wernicke, or more importantly, they'll have cardiopulmonary issues because of alcoholic cardiomyopathy, and also psychosocial issues. So which you asked in the second question, that is alcoholic addiction issue. So there are some scoring systems are there, but what we usually do now is SALT score, that is sustained alcohol use post liver transplantation. And if the cutoff is more than 5, then I think we should not consider transplant in them. So we need a strong psychiatry consultation, and also a family counseling, and more importantly, a psychosocial counseling to assess for post-transplant recidivism. And also we have to emphasize on the nutrition aspect in this alcoholic liver disease patients, because many of them will be malnourished. So that's how we have to.
Yeah, so I think it's an overall assessment of both the risk of alcohol recidivism post-transplant, their current social status, and of course, taking into care the other alcohol-associated morbidities, as you call. We'll be discussing some of them. So Parijat, how would you consider this patient vis-a-vis a patient who has had previous episodes of hepatitis, has recovered, and again gone back to alcohol? So would you be less interested in transplanting such patients who have already relapsed in the past? And how would you view that, considering our patient who has got a first episode of alcoholic liver disease?
So he is 42. He has been abstinent for last 3 months, though he may be sick and is too sick to drink, but yes, he has proven for 3 months. And this is first episode. So I think that is one positive thing which we do in assessment for alcoholic hepatitis. If they had recurrent episodes of liver disease, liver related complication and still drinking, then probably they are going to drink later on also. So this is one of the definite indicator that he deserves a transplant. So I think first episode of hepatitis, young recipient, young patient, abstinent for 3 months, I would definitely consider him for transplant. Against somebody who's decompensated, recurrently drinking, has some legal social issues, or past 65, I would not, I would not push for transplant. But in this patient, yes, definitely I will consider transplant.
Yeah, so definitely, I mean, I think most of us would agree that a first-time alcohol-related liver disease, would be looked at a little bit more optimistically than a person who has been drinking, stopping, again going back to drinking. Although it's not contraindicated, but yes.
One more point I would like to emphasize, sorry, Dr. Kaser, is if this patient was abstinent for 3 months and he did not have further complications of portal hypertension, that is varicose bleed or hyponatremia, then there may be a component of alcoholic hepatitis which has improved, and we could still wait.
Yeah,
but because even after we continue to have complications.
We are actually coming to that. So now this timing is always an issue. We have had studies in which people have been transplanted with severe alcoholic hepatitis, people who actually present with ACLF type of presentation. And then you have these stuttering type of patients who, this guy's INR is improving, his bilirubin is improving, but his ascites is worsening. So definitely he's not, he's still there, hanging in there. So what do you think, like maybe Sachin can take up that. Is there any cutoff you use in your practice? Do you see like, okay, 3 months we have to wait, or you see progressive improvement, you'll wait another 3 months. So how do you look at timing versus liver transplantation in these patients?
For the liver transplantation, the improvement in the bilirubin and the INR, which is seen in this patient, is important. And second thing, he was not encephalopathic. So there is a chance that it is the first decompensation. He is having massive ascites, but if we can wait and see the change in bilirubin and INR level, and if we can manage the ascites, he is not having SBP also, and the renal dysfunction is not much. So we can give a try of waiting this patient for the transplant and see how nutritionally we can improve and how we can see the overall improvement in this patient rather than going for the transplant. But saying that there is a DF of more than 72. So by any which ways he can go for a complication in around 40 to 50% time. So we have to have a close watch in these patients.
Okay, my next slide would come, but the question in that next slide is that would you think these type of patients, such sick patients, very high MELD scores. Of course, they were high DF. They most likely had alcoholic hepatitis also. Do you think at any point they could merit steroid treatment? Are you a big optimist regarding steroids in all patients, or you are very selective with steroids?
In our center, we are very selective for the steroids, where most of them will have some kind of infection. Unless and until there is no infection present in these patients, I would not go for steroids. And our past experience for steroid is not that good that they will improve on steroids. And any which ways on with the steroid also, there are 40% of patients will end up with the last resort of transplant.
Yeah. So I agree with you, Next. Such very sick patients should be very careful with steroids. I mean, we do give steroids, but when you give them absolutely under supervision, only 7 days to look for a response, we keep them hospitalized. And as you said, a good 30-40% may land up with a complication.
With the new study, the day 4 response of the LIL score is also a considerable point to look at, so that we are having a less time of steroid, see the response. If they are not responding at day 4 with the new study, which is coming in the ASLD, I think that less duration of 4 days also can tell you about the steroid.
That's a very good thing, because similar type of things was discussed yesterday for autoimmune hepatitis, that you look for a day 7 response. No need to just keep on giving them steroids. You have early markers of response. And if that is so, then you are more optimistic. Your timing would also depend on whether it's a DDLT or a living donor setting. If you have a well worked up living donor and your patient is kind of improving and not worsting, you might actually wait. But when your patients are listed for disease donor transplant, you get an organ, then the decision becomes even a little bit more difficult. I'll just finish off that last line. These patients continue to have, they should have counseling, not just in the waiting period, but even actually after transplant. So if you have to decrease their relapse rate, now there are some studies which say that people who have got proper follow-up with psychological counselors, even after transplant, their risk of going back to alcohol is much less compared to patients who never visit a psychiatrist or psychologist during the waiting period or after transplant.
I think the most important part here is the family support. If the motivational support in the family is there and they vouch for his recidivism, then I think we should consider.
I think the next slide, we have already taken the questions of how long to wait. There's no real guideline. It's a more dynamic assessment of how long you would wait. This patient is a bit, more controversial. Some of you would wait. I would actually not wait on this patient. Looks very sick to me with low hyponatremia, worsening of ascites. Anyway, the question is that if they improve, when would you tell them that they don't need a transplant? Do you have any personal values, bilirubin of 5, INR of 1.5? Is there a MELD score you follow? Or when do you say you kind of not delist them, but tell them that you are kind of out of the woods for transplant?
The question is,
one of you can take it. It's okay.
So suppose that the sodium is improving and he's making, he's nutritionally improving, and it does not have any further complications of portal hypertension like variceal bleed. The varices are obliterated. His ascites is mobilized. It doesn't need any more LVP. Then I think we can keep him on the waiting list, but watch, as Sachin has said, closely.
Yeah.
But
I mean,
rarely it happens like that.
Yeah, I know. In general, in my practice, when the bilirubin starts below 5, the INR is below 1.5, the ascites is very well controlled, either off diuretics or very little diuretics and a good sodium, at least more than 135. Then I generally tell these patients that they probably don't need a transplant. Still, some of them can develop a secondary infection and then come to like an ACLF. So it's more of dynamic once again. Now, so to sum it up, these patients need counseling of patient as well as family as soon as they develop severe alcoholic hepatitis and decompensation. Advice from your psychiatrist or psychological counselor regarding alcoholics is very important before you decide to list these patients. They need urgent workup for potential transplant, taking into care other alcohol-associated morbidities, as Dr. Chandan mentioned. The end decision to list these patients depend on your whole team, and there's no one criteria you can decide. And we cannot go by one score, like the MELD score, to prioritize these transplants, because some of them have ACLF-like presentation, some of them have got other comorbidities, and you use other ICU scores like SOFA and all. And in these patients who are very sick, you always need to have an optimal window for transplantation. They might be infected, they might have renal dysfunction, they might be bleeding. So we'll discuss this window issue as and when we discuss other issues in our patient. Now we know the second problem in this, our patient, apart from alcoholism, is massive ascites, hyponatremia. 1.2 kind of be a borderline renal function. I've not told you the GFR, but let's assume the GFR is 50-55. So maybe Chandan, you could take it, like, in general, how do you assess renal dysfunction in your patients? A lot of our patients have renal dysfunction, but we go by creatinine in routine, terminology. So do you also go by creatinine? Do you go by GFR? If so, what criteria do you use to assess renal dysfunction?
I think now what we should follow is that latest recommendations by the International Ascites Club, where they say the dynamic monitoring of creatinine is the one which makes a difference, because single value of creatinine has no value, because they have malnutrition, they have poor muscle mass, high bilirubin itself will cause false low creatinine. But the change in the creatinine, like in your patient, creatinine was 1.2, but suppose it becomes 1.4 or 1.5, or the GFR starts falling, or urine output is on the lower side. That is when we assess renal dysfunction. Secondly, there's some study which has shown that this cortical resistive index, renal resistive index, by measuring the interlobular renal arteries and the intralobular renal arteries, the difference in the flow based on Doppler, that is renal resistive index. It has also been shown to predict HRS in such patients. There are other biomarkers are there, that NGAL or cystatins.
Yeah, but I think those biomarkers have never been available for kind of.
I totally agree. It's only about the dynamic change in the creatinine which makes
exactly. So best is to get a rough idea of what is the baseline creatinine by looking at the kind of the best creatinine value in the last 3 months. Keep that as a baseline and then assess the changes from there, and then follow the International Ascites Club guidelines for acute kidney injury 1, 2, and 3. Now, the next question, maybe Sachin, you can take it. I mean, there is a difference between this diuretic use, frankly, between gastroenterologists and hepatologists, especially patients listed for transplant. I personally am not very aggressive with diuretics, because patients land up with many problems, and anyway, they're going to get transplanted soon. And we could do large volume paracentesis, and we'll come to that albumin story also. So what do you think, what is your aggressiveness with diuretics in patients, specifically who are listed for transplant and you want to manage their fluid overload?
I think, as you rightly said, the diuretic use for the hepatologist is different. We would like to have the diuretic response with spironolactone first, and then adding a small dose of loop diuretic if it is required. And the acceleration or the increase in diuretics will be in a phase manner, in a weekly manner. And if half a kg to 1 kg reduction in weight is possible with that, I would like to go slowly on the diuretics, because hyponatremia, hypokalemia or hyperkalemia are more problematic for the patient going for the transplant, rather than going to keep the patient very much dry and see the only urine output as a measure.
Okay, let's take that next question, which is a bit controversial, but most of us have our individual opinions on that one. Maybe Parijat can take that. Parijat, how do you use albumin in these patients who are waiting for transplant? They are hyponatremic, borderline renal function, and refractory ascites. They're requiring taps again and again. How aggressive are you with albumin, and do you think albumin works in your patients? Forget the studies. Tell me your experience if you'd like to.
I'm 100% in favor of albumin, and I use it plenty.
I just wanted to answer that percentage. Chandan, what do you think?
I think albumin is extremely important in these patients. Both the ANSWER trial and new studies are coming up for the role of different multidrug effects of albumin. But the latest trial, the data trial, did not show much, because the endpoints were different in that they want to achieve the serum albumin.
That's why I said let's not go to the studies. Clinically,
albumin improves. Basically, what I believe is albumin improves the mean arterial pressure. It improves the hemodynamics, it improves renal perfusion, it improves the sodium levels, and that's how albumin helps in mobilizing the ascites. And if you give albumin along with the diuretics, I don't think the electrolyte imbalance will be that significant as giving diuretics alone.
Yeah. So I think this is a message we wanted to convey regarding albumin, that albumin kind of can be used liberally in these patients. The exact dose and exact, frequency we can always, discuss. Now, tell me, hyponatremia is also a big problem in these patients. Albumin infusion and judicious diuretic use can control the hyponatremia. But do you believe in these other drugs, both for mobilization of ascites as well as control of hyponatremia, especially tolvaptan and midodrine? Maybe Chandan, you can take it again, and then we can have some comments from Sachin also.
I feel that midodrine has an additive effect with albumin. And we have also, we have made this protocol. We want to start as a multi-centric protocol with Professor Sudhindran's support, wherein we want to give albumin with midodrine compared to only standard medical therapy in such patients, especially in your patient with refractory ascites, because we feel midodrine improves the mean arterial pressure and albumin improves the intra-oncotic pressure, and both have an additive effect in reducing the incidence of acute kidney injury in these patients, and also in improving the sodium levels. Secondly, when the bilirubin is more than 10, and they have recurrent episodes of this portal this decompensation, tolvaptan, we have to be a bit cautious in use. And regarding terlipressin, it's only if it is type 1 HRS or they have no urine output or the creatinine.
Terlipressin is more of an in-hospital drug, while the other two are kind of can be given in outpatient settings. So maybe Sachin, you can add a bit about how frequent is your tolvaptan use? Do you think it's a great drug for raising up the sodium? And the other thing is that how comfortable are you keeping these patients hyponatremic 125/30? How are your surgeons? I mean, I've had sometimes situations sodium is 118 and the patients cannot go for a transplant. So we need to keep the sodium in a kind of a happy value for them as well. So what is your idea about sodium values and tolvaptan use?
Sodium values, yes, they are important. More than 125 is our the center's requirement to keep, because if they are below 125 and during the transplant, if they are having a surge of sodium, pontine myelonesis is one of the factor, and rapid surge of sodium is also land up in ICU, stay more. The extubation will be difficult in these patients. So I would like to keep the sodium above 125. And I use tolvaptan mainly because it is working as a non-osmolar V2 receptor antagonist, and in patients where the bilirubin is not much, and if I want to use for the shorter duration with increment of sodium, but by close watching sodium, I use tolvaptan for these patients, because increment of sodium is having a definite mortality benefit in these patients. So I prefer sodium level more than 125 and use tolvaptan, I think, with a caution.
I think that's a very good message we could give to our audience, that you could use tolvaptan. I'll show you a study in which is not that bad a drug. In between, there's some disreputation with tolvaptan. But if you take care, use it for short periods of time, not just use it continuously, you get a bit of what you call resistance to the tolvaptan effect also. So if you use it in short bursts, keep a watch on the sodium, use it maybe with albumin, and not use it in patients who got severe hyperbilirubinemia or the very sick patient, and probably it's not a bad drug. I mean, the beta blocker thing.
And one thing about tolvaptan that we have learned over a period of time is start with a small dose. Actually 3-4 years back, we started with a half tablet alternate day or that way. So we usually start with a small dose, half tablet a day, and that usually works. So if you use in combination with terlipressin, tolvaptan and albumin, I think a lot of them will mobilize their edema, ascites quite well, especially the sick patient like this. Yeah. So I think a smaller dose than what the kidney people and others use.
Dr. Kaser, can I add a comment here? Because I feel that since you're discussing a patient with alcoholic cirrhosis, whom you're managing on outpatient basis, trying to preserve him so that he can wait for a graft and he can come in for a DDLT, and our panel is very skewed, if I may say so. We don't have a surgeon. So we are taking a call on the role of albumin, the role of tolvaptan, keeping in mind that we are preserving this patient for transplant. Aren't we kind of pushing him over the edge when we're giving him tolvaptan? Because when, like you said, your cutoff is 125, it is 120 at our center. And if I get a patient, and my role is as an anesthetist and as an intensivist, if I get to see the trend of sodium, and even if it is as low as 116, and if it has stayed that way under your care, Dr. Kaser, I would take up that patient.
Yeah. So
I would not say that we need to.
Dr. Shweta, the thing is that if you take a hyponatremic patient for transplantation, you need to actually monitor his sodium peri-transplant, through transplant, and afterwards also. Don't let it become 140 on day one.
Yeah, it's the trend. Yeah.
And the sodium has got nothing to do with the transplant outcome acutely. It's the change in sodium which will give you the problems and even the tacrolimus toxicity. So
and you also
about that. Of course, surgeons are comfortable with sodium levels, and at one point we were not transplanting people. I know I had to somehow raise the sodium of a patient from 128 to 130. That was our very first transplants. With due regards to our excellent surgeons, but now we would also transplant it at least 125. So about beta blockers, one of you could take a question on that one.
Dr. Kaser, and you're giving him albumin, which will also bring up his sodium. So tolvaptan being cytotoxic. Yeah.
That's what I said. But then again, I'll show you a study, a very huge, post-marketing trial, surveillance data on tolvaptan, that it's not that bad a drug also. Remember the dosage are different. The dosage in which we use, as Sachin mentioned, are like 15 milligrams, 7.5 milligrams, which are very small doses. Anyway, we don't have much time. But
don't get scared with tolvaptan. It's a good drug to use. Only thing you need to learn the art of using it.
Yeah. So let's quickly come to one line.
The surgeons are also afraid of this albumin infusion, although all the studies promote it. Your answer trial and everything, because when you ultimately, and even the anesthetists are afraid of the albumin infusions which are pushed in, because we ultimately land up with a patient who's fluid overloaded, which he already is.
So that is the difference. We are actually trying to differentiate between the chronic administration of albumin like on a weekly basis versus the sudden albumin which we give. There are big doses we give for HRS, for SBP. So there's a bit of difference. Anyway, we can come to that. We can discuss that if we have time. Quickly, Sachin, you could take up what is your role? What is your effect of beta blockers? Do you stop beta blockers in these very, very bad patients, high MELD scorers, refractory ascites?
Yes, because I think these patients will land up because he is having massive ascites and they will land up into HRS. Already their MAP will be low. So I think it is better to stop the beta blockers if they are not having a high grade varices and there is no immediate risk of bleeding.
Yeah, exactly. So this is something else we would like to convey to our GI colleagues, who would not have this fine tuning of beta blocker use. That beta blockers sometimes in very advanced cirrhotics are not really useful, and you might not actually be able to use them because of the hypotension issue. So be very careful when using beta blockers. It actually decreases renal blood flow also after a certain extent. These are the standard indications of albumin use. We can skip them. I think we're all aware. We don't exactly use in these type of dosages. We use slightly modified. I'm sure you'll agree. But eventually we have this ANSWER trial, which has been very popular, which said that long-term albumin use actually decreased paracentesis, bacterial infection, renal dysfunction. There are other trials which said that it is not that effective. I think one of you did mention that sorting out sodium is an independent predictor of 30-day survival. So sodium, I think a little bit more work needs to be done on this sodium value, like whether we should be chasing it more aggressively or not worrying too much about it. Now, this is an interesting thing,
the patient is getting sicker. That's what's the reason, the importance of understanding sodium. As sodium is on the borderline means he's impending HRS.
Exactly. Sodium is a marker of actually sickness, and that is why now you have sodium MELD instead of only MELD. So sodium is a very, very important marker, when you assess liver disease patients. If you see liver disease patients very happy, but a sodium of 130, 129 and a bit of ascites, he's actually worse off than a similar patient with the 140 sodium. So sodium is a marker of the hemodynamic disturbance which leads to HRS, as you rightly mentioned, Chandan. So, you guys mentioned to me, and I also read that trial which is being, proposed, multi-center trial in India. I think we should do that trial because there is an interesting study which says that midodrine and albumin actually does wonders. But that's just one-off study, and it's good to have our own studies to see exactly which group it does not work. Maybe there are like different groups in which it will work. It may not work in just everyone. Now, this is about the post-marketing service of tolvaptan. I was mentioning to you a lot of patients, like almost 1,100 patients. And if you look at hepatic encephalopathy, dehydration, hypernatremia, about just 1 to 2%. So really, if you use it well and monitor your patients, it may not, after all, be a very bad drug. But again, you have to be very careful in patients who are very sick. Now, our patient, we decided to manage him with albumin 40 gram once a week. He required LVP as needed, low-dose diuretics, weekly monitoring of labs. He presented with a typical, syndrome of abdomen pain and fever, suspected SBP, did a TAP, very high counts. So now the diagnosis of SBP standard criteria, I think all of us are aware, we're not going to discuss that. But probably, Chandan, you could take up like what do you think is the spectrum of SBP organisms in your unit over a period of time, last 10 years or 5 years that you have been, in different hospitals. So what do you think is the pattern of change we have noticed in SBP?
It depends. If it is a first time SBP, it usually is
hello.
So, secondly, if it does show, it will be more of E. coli or more of gram-negative bacilli. Sometimes it can be gram-positive. But suppose the patient has been previously exposed to multiple antibiotics, then they start showing MDR, Klebsiella, or Enterococci, and all those things.
Yeah. So I would probably ask Sachin to comment. Sachin, what is your generally, look at this patient. He has been in and out of hospital. He has been in another center for 3 months. Now he's with us. He has been having LVPs, blood draws. Agreed, this is his first SBP, but he has been exposed to hospital environment. So would you still treat these patients with the third generation cephalosporin, or would you choose something else? Or in general, what is your practice regarding antibiotic of first choice in SBP patients in today's setting?
2/3 of the patients which like these patients come to the hospital with SBP, the first episode of SBP, they will respond to cephalosporins. Around 1/3 will have resistant bacteria, ESBL bacteria, where penums are used. I think I will start with cephalosporin, and if he is in and around the hospital, then there is a gram-positive bacteria which is also important, Enterococcus. For that, I will do with the ascitic tap gram positivity also, because I know the gram positive bacteria is still there in the this thing, and I have to add the gram positive cover also for these patients.
Yeah, so I would, we might run out of time. We are already 25 minutes. I'll just kind of sum it up that these patients are tricky. You could, if you think they are very sick, then you probably start with a meropenem and then scale down if they improve or you get a positive culture later on. If they're not that sick and it's the first episode of SBP, and you in your setup there are not too many resistant organisms, then you could still try a third generation cephalosporin, or what we do, we go with piperacin tazobactam. What is important is proper cultures. Although it's taught across all DM programs that cultures should be sent in blood culture bottles, make sure that they are actually sent aerobic, anaerobic, 10 ml each time you tap the ascitic fluid. Even if you tap it second time, don't just look at the cell count, send a second culture, because sometimes a resistant organism might grow in the second culture. In these patients, especially, they are precious, they're waiting for transplant, always document successful cure. So do your 48-hour tap if you're in doubt, and always do a tap, especially if you're treating an MDR, a bug. You must always document cure of SBP, because this thing will come back and hit you, if the patient develops a post-op infection, was his SBP ever cured completely or not? Now, I would come to Dr. Selvakumar. The patient has still not reached the ICU, Dr. Selvakumar, that's why we didn't involve you. But let us say this patient becomes very sick and reaches the ICU, and he's now hypotensive, and he has already been on meropenem and all. So in your ICU, what is your spectrum of organisms? And by the time they reach you, do you ever diagnose them to have fungal infection? Do you use antifungals? Do you use them empirically? Or what is your concept of antifungal use in such sick patients?
Yeah, so antifungals we have been using nowadays because most of these patients are exposed to antibacterials for quite some time in the pre-admission phases. So there is a selection pressure, and that leads to that. If there is any known colonization, and if there is a non-improvement to antibiotics for say 24 to 48 hours, we definitely go with antifungals. And if there is a shock, we would start with echinocandins and then downshift rather than start with fluconazole, because the general recommendation for antifungals is, if there is a shock, always start with echinocandins rather than with fluconazole. If there is no shock and then still there is a suspicion of fungal infection, non-response to the bacterial things, we might go with fluconazole.
So I would say, and I believe my colleague hepatologist will agree also, that diagnosing fungal infections is very difficult, and that to timely diagnose is very important. So we have to err on the side, patient not responding, very sick, already on full dose of a broad spectrum gram positive, gram negative cover, no positive cultures. We are sometimes forced to start antifungals. Among the hepatologists, would you like to add something different to what I have said, or do you also follow similar protocols?
Very similar,
more or less similar.
So I think so there have been probably some Indian studies also on this one, but this is just one representative study. I'm just telling you because this is from Brazil, almost a country like us. So they've looked at like 97 cirrhotic patients, 183 samples. The SBP was still monobacterial in most of them, but look at their multidrug resistant bacteria pattern, 40%. Extended drug resistance, which is meropenem resistance, 7%. And it's a difference between when even they come from community, 40% can have multidrug resistant bacteria. And then of course, if they are nosocomial, almost 53% are multidrug resistant. And gram-positive bacteria are also being reported a lot in most Western series. And I'm not sure if one of you hepatologists might want to add. What percentage do you think are gram-positive bacteria, especially Enterococcus? Enterococcus is very common in Western world, in United States and all. So do you see a lot of Enterococcus or other gram-positive bugs in your SBP isolates in your practice?
Enterococcus is usually around, I would say, 15-20%, but almost 80%, 80-85% will be gram negative.
Yeah. So I agree with you.
And just to
see a more of gram negative than enterococci.
Yeah.
Yeah. But what is,
and just for those who are just to add to one of your point is, whenever you send, and which I think all the good institutes do that, I think whenever you send ascitic fluid, please send the blood cultures.
Oh yes,
because
sorry, that's a very good point. That's a very good point.
Quite often your ascites will not grow anything, but blood culture will grow some bug, and that will be a real good guide for you.
Yeah, that's a very good point you've pointed out, because SBP is actually a bacteremia driven infection. It's not a direct from the gut. It comes through the blood. So the blood will also grow. Always send a blood culture. Is a very good point. Now, so this is a slightly overall data of the world that 1/3 of patients are gram positive. Now the figure might vary. You know, it's more in kind of a New York type of setting. It'll be like 60-70% gram positive. But we would generally see 1/4 and 75%, 1/4 gram positive, 75% gram negative. The important point is that this would pick up. So if you culture properly, probably you'll get enterococcus more. Remember that patients who are not responding might be having gram positive because enterococcus doesn't respond to your cephalosporins, doesn't respond to your meropenems. So enterococcus SBP has poor prognosis, partly because you don't detect it. And interestingly, 1/4 of your enterococcus may be vancomycin resistant also. So first of all, you know, whenever in bad situations, I'm sure that is the policy. And Dr. Selva Kumar, would you also agree that you would always add a good gram positive cover, say vancomycin or ticoplanin?
Yeah, we don't routinely use vancomycin. Of course, we use ticoplanin, but what happens is when we think of gram positives, already we're also mostly thinking of MDR GNBs. So if you look at carbapenem resistant enterobacteriaceae, we go with an option of tigecycline, which might have a sort of carbapenem resistant enterobacteriaceae cover, and to also cover the enterococcus. Except for enterococcus faecium, it has a reasonable cover for enterococcus. If we are very concerned, then of course we go with ticoplanin.
Yeah. So just a word of caution that we have to be careful. Tigecycline has got some of its own hepatotoxicity. So we have to use it because we are running out of options for our resistant GNBs. But we have to be careful with tigecycline. Similarly with linezolid. Linezolid can cause lactic acidosis, and careful with linezolid as well. So now this is.
I think that's why piperacillin tazobactam should be the first drug unless there is shock or renal dysfunction, because it has a partly covers enterococcus also.
Yeah, I mean actually in our practice, exactly in our practice actually piptaz is kind of the first line drug. We always step down when the patient is improving well. So now this is the general guideline that the patients who are very sick, you know, and they've been exposed, and you think that the risk of multidrug resistant organisms high, you better start them on a broad spectrum, even meropenem with a ticoplanin. Keep on reevaluating them. If the cultures are negative, good clinical outcome, you can actually step down. So no need to continue meropenem and ticoplanin for like 5 to 7 days. You can actually step down if they show a very good response, if your cultures are negative. But of course, if they're doing bad, then you revise your antibiotic policy, maybe add antifungal, add more gram positive cover, consider enterococcal. Now, this thing, you know, again, Dr. Selva Kumar, you know, you are now getting patients, you know, who are in the ICU. I mean, how are you? I mean, we'll take a few of these things only. So first of all, what COVID-19 precautions you are taking, or how are you kind of assessing them before transplant? You know.
Yeah, so the COVID-19 precautions have really evolved over the last year, I would say. It was quite significant and very strict, very all-covering. Initially, we had strict, pre-operative isolations, 2 PCRs, and PCR testing for the staffs and everything. Now, what we are basically following is we try to restrict their mobility pre-transplants at least 1 or 2 weeks, and try to reduce their cross consultations as much as possible, and teach them basically. That is the one thing which really helped. Repeatedly keep teaching them. And then we do obviously the PCRs. I know PCRs have their own limitations, but basically we do PCRs and SCORAT screening the day before surgery. And obviously the overall environmental control, the staff movement control, those things we have been doing. So none of this is absolute. These are all some layers of redundancy, which over a period of time helps to sort of prevent things. So as of now, it's been just education, PCR day before, and SCORAT screening. That's the core of the testings.
So maybe Chandan, I could ask you the next question. Do you do nasal swabs, rectal swabs in all your pre-transplant patients? How do you interpret those results, especially rectal swabs growing resistant gram-negative bugs? I mean, do you do them first of all, and if you do them, how do you interpret them?
In nasal swab, I think if you're asking for the COVID, yeah,
no, not COVID. Sorry, I'm talking of general nasal swab for MRSA and all.
Okay. Yes, we were thinking of the protocol, but suppose the patients did not have much antibiotic use pre-op and did not have recurrent infections, then we can get away without it. But if they had previous history of MDR, Klebsiella and all, then definitely rectal swabs have shown good data. There's a very encouraging data about use of rectal swabs for detecting this multi-drug resistant bugs pre-op and then taking precautions accordingly.
So you mean to say if a patient has never had an MDR infection, but if he has MDR positive in the rectal swab, you would modify your peri-op prophylaxis accordingly? Am I right?
If the patient has a high MELD, like this present patient, and he had recurrent hospitalizations and his rectals, and he had one, but he did not have an episode of MDR bug growing anytime, but he had recurrent hospitalization, such patients will benefit from a rectal swab. But if a patient had MDR Klebsiella or MDR bugs grown previously, then I think we can get away with rectal swabs and then just treat them with empirically high-end antibiotics pre-operative.
Yeah, so that's a very good point. If they're already MDR positive somewhere else, then the rectal swab is not going to give you additional information. So I mean, it would be
a point I would probably add is this rectal swab is actually, they're not doing cultures nowadays. It's more of a genotypic directly. You can do a CARBAR genotypic testing, which gives you the the prevalence of beta lactamases. And in case if you have a say OXA48 or a NDM gene there, we might have to basically in the post-op setting, if there is a sepsis, so basically we just have to keep that in mind. That's what we usually follow. Like it may not change the prophylaxis, but it might change our empirical antibiotics if something goes wrong in the post-op.
I will ask a provocative question to maybe Parijat and Sachin, both of you, one of you can take it. When would you not transplant a patient who is having one of these infections? I'm not saying active infection, but let's say there's an MDR positive urine culture, you've tried your best, you've not been able to eradicate it. Would you still transplant him or would you hold off the transplant?
No, so I think my take is one is if you have got this MDR infection, treat them for a longer time. So say 10 to 14 days and give them some antibiotic free period. If they are stable, their infection markers are stable, then I would transplant. And in addition to that, I would definitely take into account their frailty and nutritional status, their mobility. So I think in MDR infection, it is important that you treat them for 10 to 14 days, give them some time period of antibiotic and then transplant them.
Yeah.
Because you may just suppress and post-transplant, they will just flare up and die on day 3, day 4, day 5.
Exactly. So I think it's again a very subjective thing, center to center, person to person. It's a complicated issue. There was a point of time in which, when I was training hepatology, we would actually not transplant anyone who has got MDR in the urine. But now we can't do that. I mean, almost 50% patients have MDR, one culture or the other, blood, ascitic fluid. So we have to be judicious, and that antibiotic-free thing is a very important thing. Observe them for a few days to see that they're not deteriorating, so that they've really cleared and you're not actually transplanting them while on antibiotics. So that's a very important thing to understand. Now let's come to, anyone?
A point taken about urine culture. If they are having some obstructive uropathy and there is a resistant bug there, then free interval of antibiotic and see how the flora is growing the culture. And we can take them on antibiotics for the transplant.
Exactly. Maybe Chandan, you can take this one. Like, these patients need nutritional assessment. So what is your general protocol of nutritional status assessment in these patients? What would you say, how aggressive are you with nutritional interventions in these patients?
We have to highlight sarcopenia in these patients. And first of all, this patient is an alcoholic liver disease. And secondly, he's having recurrent episodes of decompensation. So it's more like a accelerated starvation with increased requirement. So sarcopenia we can classify as muscle mass and muscle strength. So muscle mass, we have this different tests, anthropometric tests are there, and skeletal muscle index is there. And the muscle strength we assess by this frailty index, that is at chair standing, and that walk, as well as this hand grip strength. So this is how we have to assess nutrition in these patients.
Yeah. So, I mean, I think I'll have to really sum it up that malnutrition, you have to understand, is extremely common in cirrhotics. And your patient might look obese, you know. I mean, we have NASH cirrhotics who might be actually obese, but actually they will have poor muscle bulk. So simple body weight and BMI has got no value.
Sarcopenic obesity.
Fluid overloaded patients might actually be much more malnourished than what they appear. Poor nutrition status has been correlated with high post-op complications. Malnutrition is assessed, as you said, by skeletal mass and strength both, and then the two words used are sarcopenia and frailty. Now, the biggest challenge is how to improve nutrition. Assessment is still okay. You can include as part of your protocol. So how to improve nutrition is a big problem. Actually, sarcopenia is not very difficult to assess. All of these patients get CT scans. You just have to tell your radiologist what to do. They know how to assess sarcopenia. At the level of L3 upper border, you look at the muscle cross-sectional area and multiply by the height square, and there is a ratio you get. So sarcopenia is very easy to assess as long as you got a CT scan, which all your patients have. Now, sarcopenia and frailty both are not captured by MELD scores. So we have shown, I mean, there are studies shown that MELD plus sarcopenia or MELD plus frailty, the different scores, that especially in the low MELD patients. So let's say you get a low MELDer 14, 15 MELD, but he's quite sarcopenic or his frailty scores are high. You might say your MELD score is very low and you don't need a transplant right away. I mean, this is very important for patients who refer patients for transplant, gastroenterologists who refer patients. So you might have an alcoholic of MELD like 15, 16, he stopped alcohol, maybe he'll improve. But if he's frail and if he's sarcopenic, then believe me, his mortality is going to be much more than a patient who has got better nutritional status. I hope my hepatology colleagues will agree. Now, the main problem is that, you know, how do you improve sarcopenia? The realistic improvement in sarcopenia is difficult. So Parijat, what do you do? I mean, how do you manage nutrition in your patients? All of them get high protein diet, all of them get supplement. Do you consider tube feeding? Would you ever consider growth hormone? Parijat?
So, we may give them diets, prescribed diets. In hospital, we can control to some extent, but I don't think they consume even more than 50% of what we prescribe. At home, it is even a worse situation. So I think what is important to insist is whatever you eat something which is calorie dense. So I think the quality of diet that they consume, because they can't eat a large volume of food, you accept it. So I think what is important to insist is that whatever you eat, you insist that they eat something calorie dense, and according to local food habits and local diet, you can prescribe accordingly. What I usually do, and since last 2 years, is especially patients who are following an OPD, I always tell them to buy 1 or 2 kilo dumbbell, a stepper, a steady cycle, and a TheraBand, and tell them that you lift weights 1 or 2 kilos. It's not difficult. Climb one step, one stair, and do whatever is possible with this TheraBand. It's very easy, simple, and maintains their activity, maintains their muscle mass and their physical activity, which is more important than nutrition. Because honestly, I don't know if everybody agrees or not, there's a limit to which we can improve their muscle mass and nutrition when they're so sick.
No, I do agree.
That's my opinion.
You know, it's a big challenge, and they themselves follow many misconceptions about diet, not to eat this, not to eat that. So it's very important to clarify the exact restrictions. There aren't actually any restrictions apart from maybe a bit of fluid and maybe a bit of salt. Even with salt, we are nowadays a bit more lenient than in the past. Nutrition supplements, I'm sure we all use nutrition supplements in some form. It's important to supplement zinc and magnesium. Most of these patients are deficient. I mean, do you use tube feeding? Have you been a big fan of tube feeding, maybe Sachin or Parijat?
In hospital, in some patients, but not as a outpatient.
Yeah, so in our setting, you know, sending them back home on tubes with pumps is not a very viable option. Branch chain amino acids, you know, they are expensive, not very palatable. They are supposed to improve nutrition balance, but again, it's challenging to keep them on branch chain amino acids. And we don't have much time. We would have discussed a bit about branch chain amino acids. Similarly, I think we have discussed about frailty, about the different ways of assessment of frailties there. The idea is that we must all learn as hepatologists to assess both nutrition as well as frailty. It's actually not very difficult. It's pretty easy. And whenever possible, you know, involve physical therapists, physiotherapists, and dietitians in your practice, especially in transplant centers. Patients should follow up with these two people on a very regular basis, because you yourself might be too busy to counsel these patients. I think we have done that. Now, this is last. We'll end up with Dr. Selva Kumar, because patients do land up in ICU and from where they go to transplant. So Dr. Selvakumar, this patient recovers from his SBP, but develops melena and hypotension, gets admitted to your ICU. There are small varices, probably some severe PHG. We really don't know where he's bleeding from. He develops a fever, a bit of hypotension, low dose noradrenaline, little bit encephalopathy. You see, creatinine is worsened, INR is worsened, sodium is further down, bilirubin is worsened. So he is probably low-grade infection or some other sort of thing developing, and probably a cadaver organ is available. Now the transplant surgeons walk into your ICU. How would you, look at this situation, and would you be happy transplanting him, or would you take 24 hours to kind of optimize him? Your final word on this final candidacy for transplantation.
Yeah, so I think this is a bit of a complex question. So whenever we have a situation like this, like a transplant question comes up for ACLF patients, we usually have three things in our mind. First one is the need for transplant, which I think has been already proved, and any pre-critical care contraindications in terms of abstinence and the other cardiorespiratory comorbidities. Once that is done, the critical care assessments and risk stratification comes. And the most important thing here is the amount of organ failure and the sepsis, obviously. Sepsis is obviously very difficult because sepsis and ACLF shares a lot of features, the SARs, the organ dysfunctions. But it's an assessment based on clinical reviews, markers, and the cultures and the dynamic changes. So if there is no overt sepsis, and if there is no increase in sepsis, that would be still okay. So in this patient, obviously, 24-48 hours of antibiotics would be ideal, but in a cadaver organ is available, then we might be considering that also if there is no overt evidence of sepsis or source.
One last question.
Yeah.
Do you follow ProCal, CRP, and these rapid culture techniques?
Out of the lot, we don't follow CRP, obviously. The rapid cultures and the gene studies, we don't usually chase it because they are too non-specific, very sensitive. They pick up a lot of things. ProCal by itself on one value obviously has a bit of problems, but a trend of ProCal has been quite useful for us to understand how it is. It's a combination of ProCal trend and the cultures and the clinical things.
I think a final multidisciplinary meeting, hepatologist, intensive care, surgeon, patient's family, because this would be a high-risk transplant, so I think would be very important. So, I mean, we would end at this, Chandan, Parijot, Sachin, would you like to add some, finishing touches, or we should end?
Well, I just want to ask about the use of Cirrhotic in this patient when you are assessing for transplant. Whether can you take this patient or we have to optimize him quickly and some hypotension along with antibiotics?
Sorry, Chan. I didn't hear it. I think it's
just to ask Selva. Of Cirrhotic in this patient with sodium 122, whether at that quick juncture to get a window period for proceeding for transplant.
So regarding the organ failures, I think this is what one of the organ failures, of course.
Suppose if the patient chest is okay, ventilator parameters are not bad, and not too much pressures, small pressures requirement, whether will dialysis Cirrhotic.
So the organ failures, out of the various organ failures we assess out of the 6, basically the worst obviously would be the chest. That's what we are more worried about, and then comes your circulation in terms of the inotrope dosage and the lactate and the perfusion markers, and then comes the kidneys. We have been handling okay with managing patients with renal dysfunction, with oliguria, with metabolic derangements, but for a ALF patient, of course, CRRT we have been routinely taking up. For a CRRT, for a ACLF patient with renal replacements, it has been a case of exceptions rather than a routine, actually, because generally speaking, in this situation, in this level of organ dysfunctions with the CRRT, it becomes a bit more difficult to manage in the post-op. Having said that, if sometimes we use CRRTs for other indications, say for example as a cytokine modulators or as a filters, as a bridge for your ACLFs. So if the indication is not really acute renal shutdown, or it's a para-renal indication, then we might still be okay. But of course, as Dr. Kaser was saying, it needs a good multidisciplinary discussion and a discussion with the family about the post-op risks.
Yeah, I think we have burned our fingers both ways. We have not transplanted people and they died because of not doing transplant, and we have transplanted people who have died because of rampant sepsis. It's a very difficult decision. These ACLF patients are very difficult decisions. And it's extremely important to impress upon the family that we are doing kind of a high risk, high mortality transplant. Whatever decision you might take, there's no single marker which you can say has ruled out infection. In an DLT type of setting, you still have some time to optimize. 48 hours, 72 hours, you can use them. But in a DDLT, it really becomes an extremely difficult decision to take. I hope all of you will agree. So with that, I would end. I'm not sure whether I'm supposed to take these questions. Most of these questions have been already answered. Chairpersons, would you know?
Dr. would you like
Kaser, can I make a point?
Yes, please.
So this is because this is a course for those who are starting or initially into transplantation. I think all of us have learned or will learn hepatology management, and we do more or less the same. I think what changes the game, especially with alcohol, increasing alcohol and non-alcoholic. I think we need to learn a bit of addiction medicine and nutrition and physical rehab quite well than what we are focusing, because that's where the game is changing. We need to understand addiction medicine because we have a kind of set up a addiction unit now which supports us, and we need to learn some principles of motivational counseling, motivational interview, and it does make a difference. So I think what is going to make a difference is two. One is addiction medicine, our approach, and second is our intervention at the nutrition and physical rehab. I think that is very important. Hepatology, all of us will do more or less the same.
I think you are right. These are the most ignored aspects of patient care. The alcohol addiction part, the nutrition part, and the physical rehabilitation part. And even when it comes to NASH, as you rightly said, we are seeing that most NASH patients will get obese after transplant. That's the other end of the spectrum.
Absolutely.
So they're going to get metabolic syndrome, diabetes. I've had patients that 2 years after NASH transplant getting acute MI. They had a proper cardiac eval 2 years ago. So this is again changing, and we probably need to relook at how we manage these patients both pre and post transplant. I agree with you. Yeah. Charles?
Yeah, Dr. Ashok, you want to make any comments about ACLF and ARC, your experiences? I think Ashok has gone offline. Dr. Shweta?
I have a question. So since we are optimizing this patient, and we probably will be faced with this situation which Dr. Kaser brought up, that suddenly we have to transplant him. So how would you do a cardiac evaluation of this patient? And again, my concern on weekly albumins.
We have already, coming to this patient in particular, we have already evaluated him.
Yes,
but as a protocol in our program in Bangalore and Kochi, we do a cardiac echo, just before the transplant, as part of a protocol, just like we do an ultrasound scan to look for portal vein thrombosis and other issues. So, but the actual cardiac evaluation, the dynamic evaluation has already been done, So because I told you that this patient has been evaluated for transplant. So that part I hope is understood.
So since there are no questions in the chat box, I think we can close this wonderful meeting. Charles, congratulations. It was an excellent meeting. Thank you, Dr. Kaser, for rapidly going through this.
Yeah, thank you.
Covering all aspects.
Not just for this session, but for the entire meeting. It was a really lovely meeting. Very good presentations, and really a learning experience. I'm sure a lot of people have attended, more than 300. It would have been really a thrilling experience for all of them. We look forward to similar meetings, all of you. Thank you so much.
Thank you, chairpersons, Dr. Shweta and Dr. Ashok.
Thank you, Charles.
Thank you, panelists. And thank you, Dr. Kaser, for moderating the session. And that brings us to the end of 2 days of academic feast. And I'm sure everyone enjoyed the talks and the format of the course. If you have any suggestions for future meetings, please send it to us. We have a suggestion form. And the recording of the course will be available on the LTSI website. And we request those who are interested to become members of LTSI to join us. And this evening, I also take the opportunity to thank the international and national faculties, the chairpersons, speakers, panelists, and moderators who, despite the busy schedule, accepted our invitation to be with us and shared their vast experience. And all this would not have been possible without the academic support of Emcure. I thank Mr. Sunil Lonthe and Mr. Sandeepan, who made this event a success. And I also thank Somnath and the MICE Ideas for the technical support for the smooth conduct of this online course. Last but not the least, I thank all delegates who attended the course and hope they had some take-home points. And I now hand over the session to Mr. Sunil Lonte of Emcure for the concluding remarks.